So I thought I'd maybe take just a few minutes to pause and have you think like a rheumatologist for a little while. So we treat many different types of inflammatory arthritis, psoriatic arthritis being one that we share mostly with the dermatologist. But you might go back to med school and wonder how we classify all this and what's rheumatoid arthritis and how lupus all fits in. So in the family of spondyloarthropathies, we have to remember that these are all tied together because they touch the spine or the axial skeleton, while many of the other arthritides that we take care of do so less. So here is a very typical slide that we use with our trainees to kind of put together where spondyloarthritis falls in. So as you know, psoriatic arthritis, what we've talked about this afternoon, but the prototypical one is ankylosing spondylitis. And then we have the undifferentiated, the juvenile, the IBD arthropathy, as well as reactive arthritis. So it's not new for this crowd here. We all know that it affects the skin and the joints, and we can try to image that. But what we are finding out now more and more is that we also have systemic features of psoriatic arthritis, and that's probably where we're going to become a little bit more flexible in the type of treatments that we use. So today was pretty comprehensive, and we're still going to hear from Dr. Gordon about another mechanism. But I think how we're going to choose is probably based on not only the skin and the joints, but additional structures that are affected. So what we see here is something called enthesitis, and I'll talk a little bit more about that. And then we also have dactylitis. So these are dactylitis is sausage toes or sausage fingers that we see that can also cause pain around the joint, as well as enthesitis, which is where the tendon attaches to the bone, which can also cause swelling. So as you can see, these spots are all near the joint. So it becomes really challenging trying to figure out which exact structure is problematic, and also which drug to use. So this is probably one of the most important papers by Sherlock. So here what I want to emphasize in psoriatic arthritis or the spondyloarthropathies is the action is here. So what is here? Here is where the tendon attaches the bone, and it's the enthesis. And what we found is that there is an increase in IL-23, which then helps expand all the T cells, which then causes all the scenarios that we see. So the question is, what causes this increase in IL-23? And so there's a lot of theories, but we actually don't really know. And the reason that this slide, I think, is so important is because this is really different from our prototypical rheumatoid arthritis. So rheumatoid arthritis starts, the action is in the synovium, and the synovium is the lining of the joint. So it starts at the joint. So this is different because psoriatic arthritis starts at the enthesitis area, which is sort of outside of the joint. And this is really what has allowed us to have different treatment targets in rheumatology. So there was once where we just had methotrexate and we used to treat all different types of inflammatory arthritis, and now we're much more targeted. So in blue here are some of the theories of what might cause an increase of IL-23, which then would lead to the cascade. So there's a lot literature on the microbiome, a lot on genetic risks. There are patients that are more prone to have HLA-B27 positivity and an unfolding protein issue. And then also there is a theory on biomechanical stress. So these points of enthesitis are usually in areas such as the heel where you can get a lot of trauma, and whether trauma can also induce IL-23, which then helps recruit and expand more T cell expansion, which then causes this cascade of not only what we see in the skin, but also osteoproliferation and inflammation and bone loss, and what we see on X-ray. So in addition to what I just explained in the bones, there are a lot of comorbidities that happen, so it's not just a skin and joint disease, and here are some of the popular comorbidities. We heard a lot about cardiovascular disease today, as well as metabolic syndrome, fatty liver, as well as depression. So here's a slide that I put together for this talk that kind of helps me think about all the different classes. So I won't have time to go through all the mechanisms, and all these great speakers ahead of me and behind me have done a great job explaining some of these. But I thought it would be helpful just to see, although we're all familiar with these medications as they're emerging treatments, they do have different efficacies around psoriasis, psoriatic arthritis, and ankylosing spondylitis. And here, the ones in greens are the ones that are approved. The ones in yellow are the ones that are being studied in more advanced phase 3 trials. And then the reds are the ones that stopped. So I just wanted to bring your attention to, although ankylosing spondylitis has very similar mechanisms to psoriatic arthritis, it is not a slam dunk that once they're approved for psoriasis and psoriatic arthritis, that they will be approved for ankylosing spondylitis. So this is kind of tricky for us because the mechanisms for this I just showed you in the very first slide is that they share very similar mechanisms. Yet for reasons that we are still trying to understand, they don't necessarily will be ameliorated, the signs and symptoms, with the same mechanisms. So I'm just going to go over briefly each of these by category, but not as in depth as all the other speakers have. So Tony has done a great job of telling us about TNF inhibitors. So what I thought I might do is just maybe look at some of the nuances. So in terms of TNF therapies and psoriatic arthritis, I like this slide. This is from Chris Richland, where we're putting ACR 20, 50, 70. These are our measures similar to PASI, so these are our disease activity measures. So we're really jealous of rheumatology, of dermatology, I mean, because we can never get these scores as high as you can. So, you know, for me to see PASI 100, we can't even dream that in rheumatology. So the green is the ACR 2050 superimposed to the reds, which are the PASI scores. So clearly you guys are able to clear the skin better than we can clear the joints. And so we are still you know, looking for that ACR 90 or ACR 100, which we do not have at this time. So this is just sort of a gestalt looking at skin versus joint with the TNF inhibitors. And then I, instead of going over all the TNF studies, I thought, well, what's new for us in PSA? So some of this was already in Tony's talk, but what's new for us is IV golimumab. So we've had a lot of experience with this in RA and now in an IV form, ARIA for PSA has shown some good efficacy through 1 year. And importantly, this also has some radiographic outcomes. So in addition to feeling better in the pain of joints, we also look at radiographic progression as an outcome measure. So IV golimumab was also able to maintain clinically meaningful differences in both the joint counts as well as radiographic progression. Cimzia, I think, is exciting because we had heard from Tony earlier that there's also these newer studies in crib and cradle. So many of these patients are younger, female age, childbearing age, so we have to think about whether or not they should carry on their therapy while they're trying to get pregnant and when they're pregnant, and then for breastfeeding afterwards. So this crib and cradle study has really helped us distinguish a little bit amongst the TNF, so this is the reason that I wanted to bring it to light, that it may be in some certain populations this is going to become more desirable. The other thing I wanted to talk about is methotrexate, which Tony did a great job outlining. And so the question is, do we add methotrexate? Do we not? So as a rheumatologist, we are very, very comfortable with methotrexate. And we also know that in our rheumatoid arthritis trials, it has always shown us to be better in combination than alone. So you have to understand where we started from. We also do not biopsy really much on methotrexate. We follow their LFTs, and I know we differ a little bit, and Carly talked about that as well. So the big question is, in psoriatic arthritis, why would it differ? Why can I not use the same concept? And many studies have tried to look at this, and I know that the studies vary whether we should use it or not use it, but I think that a typical RA patient probably does not have the same metabolic profile as a typical psoriatic arthritis patient. So we're talking about patients with sort of different metabolic syndromes, different BMIs, and we think this is why we see the differences. So we have something in RA called RA cachexia. So many times our RA patients are thin. we do not see the same type of patients that we see in psoriasis and psoriatic arthritis. And I think that alone probably explains some of the differences and why we don't see some of the efficacy as we do in RA. So when we weigh the differences, we're not even sure as Tony has alluded to, we still have different guidelines. Our European EULAR guidelines versus our GRAPPA international guidelines and our ACR guidelines are still not clear on the use or not use of methotrexate. But I did look through many studies, and there seems to be more evidence weighing using methotrexate as an option for certain populations. The other thing is using methotrexate can also perhaps extend the life of our TNF. So here's one of many studies that I know you've seen already, but showing that certain TNFs, such as etanercept, may be used in monotherapy, while infliximab is a TNF that really needs to be used with methotrexate, because if they don't, we find that we cannot sustain its efficacy on longer term. And then adalimumab, as you can see, is in the middle of those two in terms of drug survival. So I'm not going to go into Arava. This is an oral option for us. We do use it in psoriatic arthritis and rheumatoid arthritis, but it's less efficacious in ankylosing spondylitis. We also have a Primolast, which we've talked about as well, which, as you can see here, is used in psoriasis and psoriatic arthritis, but not so much in ankylosing spondylitis. A Primolast, here's just a study just to orient you. We use ACR 20, ACR 50, and 70 to look. These responses are not as robust as we see in our anti-TNF, but you do get some efficacy. So perhaps patients in more mild forms would use this drug. But in terms of people with really severe joints, we probably would not reach out to this as much as some of the other mechanisms that you heard about. But a Primolast does have a rather safer safety effect profile, and so in many patients we do use this. IL-17 we just talked a lot about, and we'll go through that briefly. So IL-17, as we know, has multiple cell targets, so this becomes very attractive to us in addition to the skin and some of the joints, is that it does affect many different pathways that can lead to bony erosions, and so it has a lot of good efficacy in terms of all the different ways that joints are affected by psoriatic arthritis. The mechanism of action I won't go into because we just had a great talk beforehand. Secukinumab is efficacious in both psoriatic arthritis as well as psoriasis, and here are the studies that you can see against placebo. So I'll quickly go through this. One of the biggest questions that we have is on this slide is, well, how do we really compare it to TNF? So we have some head-to-head, but this was not meant to be a head-to-head study. This is just kind of to show you in a summary form to see where secukinumab goes against other TNF. So similar in sort of the ACR 20 response in the 50 range, and some with a little bit of variability, but pretty much the same against placebo. As you know, we have other IL-17s that are recently approved. We also know that brodalumab has had a pretty rocky start, but now approved for psoriasis. Some of the newer mechanisms is bimekizumab, which also looks at not just IL-17A, but looks at IL-17A and F. It's being currently tested in psoriasis, psoriatic arthritis, as well as ankylosing spondylitis. IL-1223, we heard from Neil, has been done well in psoriasis and psoriatic arthritis, but not so much in ankylosing spondylitis. Has a really good safety effect profile. In terms of the ACR 20, 50, and 70, probably a little bit more modest response than what we see in anti-TNFs, but nonetheless, we do use it for psoriatic arthritis. Obviously, in patients that probably have a little less joint but more skin, there's also a great dosing regimen for this, as you know, where you can do it every 12 weeks. We went over this study. I was just trying to pick out things that were a little different with IL-1223. This is Joel Gelfand's VIP study, which we talked about in terms of reducing vascular inflammation. Now moving on to IL-23, which you guys are more familiar with it than we are. These have been, some of them have been approved for psoriasis, but really in the much earlier stages in psoriatic arthritis. So we're only getting sort of abstract forms in our national meetings, but it does show some numeric improvement of psoriatic arthritis. Risankizumab is one of the newer ones, also in phase 3. Looking at IL-23 blockade. So I'm going to spend a little more time on JAK and abatacept. These are probably ones that we are more familiar with in rheumatology because we have been using it for rheumatoid arthritis. So tofacitinib is looking more in the signaling pathways. So these are looking at cell receptors and influencing intracellular mechanism. So there are many different JAKs that we can block. Here's a quick review. So tofacitinib is the one that is the furthest along and has been approved for psoriatic arthritis, and baricitinib is close to being another JAK inhibitor used in rheumatoid arthritis, but also some early phases in psoriatic arthritis that's being in development phase. So tofacitinib, we have 5 milligrams and 10 milligrams. Here is looking at efficacy with a adalimumab comparator. So as you can see here, the ACR 20, 50, and 70 do have a little better efficacy at the higher doses in the gray bar, as you can see, compared to the orange bar. We have been using this more frequently in rheumatoid arthritis. This is a good oral option for many patients. What we are doing now in practice is probably before we start, we try hard to get their vaccinations for Zostavax because there is a little bit bump or signal for recurrent shingles in our patients. So that's one thing that we do look out for. There is a new vaccine coming out now. So as you know, Zostavax is live, so you can't really use it once they're on a biologic. So we're trying to get that window of time to get them vaccinated before we start them. But there is a new vaccine that's coming out that is going to be non-live for shingles that can be used. So lastly, abatacept, we use this, it's both in IV and sub-Q form that were recently approved for psoriatic arthritis. Unfortunately, in the pilot studies for ankylosing spondylitis, once again, that disconnect where there's very little response. So the Astria study showed here, you can see using abatacept, a T-cell co-stimulatory in phase 3 here, that you can see that there's efficacy of the abatacept group compared to placebo, with trends towards musculoskeletal improvement as well as skin. Probably a little bit more significant for joint coverage than we see in skin coverage. We talked, I think someone mentioned the raw gamma T inhibitors. These are one of the newer ones, sort of more of the frontline inhibitors that a nuclear receptor believed to drive IL-17A, F, as well as 23 expression, small molecule modulators. So I thought I'd just take the last few minutes. I know this has been a lot of mechanistic slides and a lot of data slides, but I thought it'd be important to kind of go over how we're thinking about treatment strategies and how they might differ from the way that dermatology looks at this. So just as Dr. Cooper has talked a lot about looking at treat to target, we also have been trying really hard to come up with a consensus of when does a patient get better with psoriatic arthritis. So one of these measures is minimal disease activity, or MDA. So what we look for is look at these 7 domains, and we see if we can hit 5 of these 7 domains, and if we do, then these are considered minimal disease activity or low disease activity. So we not only look at joint count, but we look at swollen joint count, enthesitis count. We do have a PASI score there, a function score, and then a patient's global as well as a patient pain VAS scale. And if you hit 5 of the 7, then we consider this patient to be in minimal disease activity. So as you can see, we have a lot more measures to kind of balance and see and try to attack with many of these treatment options. We also have a study called TICOPA, which is similar to a treat to target concept that you guys have in terms of trying to meet low disease activity. So here what we're doing is taking a group of patients that just have standard of care. So they come in when they want to come in to see their rheumatologist, and then we have a tight control arm, which is in the green, which they come every 3 months, and they have a measure, and if they don't hit that measure, they have to have a change in their treatment regimen. So that's called the tight control arm. And so what we want to know is whether doing that tight control versus just standard of care changes your outcome at the end of the day. And what we see is that tight control does show better than standard of care. So what we see here in the blue bars are the tight control, the green bars are the standard of care. And these are for joints, and then I have a next slide looking at skin. But in both skin and joints, the tight control is associated with greater improvement over people with standard of care. And here's the PASI score, so once again showing similar changes where tight control wins over standard of care. So in terms of treatment gaps and what we know, not everybody responds to TNF, so we are really excited that there are new treatments that are out. Dr. Cooper did a great job trying to explain, that we don't have a great biomarker to predict which patients will best respond, so there's still a lot of trial and error as we move forward. There are insurance issues around there, and there's novel treatments that address skin differently than joints, and then as well as comorbidity, so we're balancing all three. And then I think the biggest thing that I do want to tell you about, and this is unfortunately an older slide, but I had some slide sets looking at picking up psoriatic arthritis early and patient reported sort of questionnaires. So there is sort of a lack of knowledge of how we jump from psoriasis to psoriatic arthritis. There are things that we look for, like scalp and nail diseases, that give us a higher probability of getting into psoriatic arthritis, but it would be great if we had something better. So we do, Abrar and I have co-developed something called a PACE questionnaire, which is a questionnaire that patients can fill out, and what they do is try to ask them a little bit more about their inflammatory symptoms, and if they score higher on some of these, higher than a 43, for example, then that would help the dermatologist perhaps refer to rheumatology a little bit sooner. So there's a lot of changes out there that we're trying to promote and to try to co-manage with dermatology to hopefully try to get to these patients earlier before they have irreversible joint damage.